Good evening, everyone. This is Rhea Biswas, Faculty of FST and Exploration Foundation. Today is the day 2 of the workshop. So, today we are going to deal with one of the important topic, that is nutritional support. We are discussing about the critical illness and the critical care in the ICU setup. So, in that, we are having one of the topic for the day 3, that is optimal timing of nutrition support in ICU. It can be early versus delayed feeding. Along with that, we will discuss muscle wasting, sarcopenia in the critical illness. First we will move on to the first we will look into the critical illness part. Why we are discussing the critical illness? See, critical illness is one of the important part because here we are dealing with multiple factors but in a molecular level. Okay, so critical illness is the condition, is the phase where patient is critically ill and dealing with various metabolism. It can be hypermetabolic and hypercatabolic. Anabolism process is very slow in this phase. So here we usually see so much breakdown of the muscle of glycogen and fat also in a longer duration, and with that various types of metabolic changes we can observe in this phase. Along with that, there is increased in the energy expenditure, protein breakdown, and there is rapid depletion of the nutrient store, because your body at that time wants excessive amount of nutrients for the recovery. So in this phase, we have to uh, develop the nutrient support in such a way that to prevent malnutrition, to prevent muscle wasting, sarcopenia, and build up the immune system, because that only help in recovery. Here we will discuss that early feeding and the delayed feeding. There we will discuss that why the feeding process and the timing is very important. Then we are dealing with the nutrients, which type of nutrients work in which way for a critical illness patient and in which timing we have to give them. So basically we will consider early feeding up within 24 to 48 hours, and delayed feeding will be after 72 to more than 96 hours, like that. Okay, so in this way the nutrition support play a vital role in the ICU patients. Now we will discuss how the metabolic changes occur. Okay, metabolic changes are dealing with hormones, inflammatory mediators, along with the nutritional means the nutrients. So various metabolic changes we can see. So in a core level, there are hormonal changes, because a critical patient usually their physiology is going through a stress. Along with that, there will be mental stress also. None of the patient love to be in a hospital. Okay, so in the hospital setup there is a stress condition. uh, with the mental stress there is physiological stress. Due to these both stressed and the depressed condition, we have various types of hormones which increases, like catecholamines are increases. Along with that, cortisol is increases. So we already know cortisol is a stress hormone. So while I am in a stress condition, like what will happen to me, how the surgery will go on, how much time it will require for me to recovery. So these are the stress condition we are dealing with. So these stress condition will build up more cortisol in our body. Along with that, glucagon secretion is increases, so it will break down our glycogen stored in our liver and release more glucose. Why? Because our body needs more energy. As I told you that there is increased energy expenditure, so our body need more energy at that time. So for that, we have to break down the energy stores, that is glycogen. So glucagon only the uh, hormone which actually helps to break down the glycogen to convert to glucose. So in this way we get the instant energy. Along with that, growth hormone secretion will increases, like we can see here in this picture. In a normal condition, usually hypothalamus gland actually secrete CRS, that is corticotropic releasing hormone. Along with that, it signal the pituitary, and it will release adeno corticotropic hormone. Then it signals the adrenals, and then it will release more cortisols. So in this way, this is a normal condition where cortisols are released and that it will go to target cells. But when there is negative feedback and when there is prolonged critical illness, we have seen more amount of glucocorticoid release receptors, due to which it inhibit that corticotropic releasing hormone. And due to this inhibition, we will see that ACTH can't able to release the amount that is needed for our body, and there is suppression with that secretion, due to which there is adrenal atrophy can be seen, loss of zonulation of the structure, and the expected cortisol, which amount is lower due to the signaling of this normal condition. In the stress condition, it will increase. So due to disruption of this pathway, we can see the cortisol hormone releases more, and due to cortisol hormone releases more, there are various functions in our body is been hampered due to this stress. So let's move on to the metabolic changes, what we can see here. Okay, before going to that, we will just look into the insulin level. Okay, see, growth hormone secretion actually inhibit the working of the insulin. So, how it is going on, I will just discuss that. In the stress or critical condition, it has been seen that more cytokine is released in the body. Due to excessive release of cytokine, it will signal the release of growth hormone. So more cytokine, more growth hormone release. Okay. So that growth hormone binding protein, actually what happened? It synthesized in a very limited amount, and due to which it will, in a negative feedback, it will increase in the synthesis, and it will have a receptor like an insulin receptor in the normal condition. But what happened, due to excessive increase, that receptor will activate tyrosine kinase. This tyrosine kinase will inhibit the insulin activity, actually insulin kinase activity, and it will inhibit the uptake of glucose from the cells, from the blood vessels. It will reduce the storage of the glucose. So various types of anti-insulin effect we can see in our body if there is excessive increase of growth hormone. And there will be catabolic phase, and with the help with the catabolism, there will be low storage. Along with that, there will be what we can see that with the low storage, we can't able to store the glucose itself also, due to anti-insulin effects. So these are the effect we can see here. So there are some list out I have seen given there, that growth hormone dysregulation in the critical illness will cause decreased insulin sensitivity. Along with that, there is increased lipolysis, means breakdown of the fat is increases. Then glycogenolysis increases, decreased glucogen synthesis, and protein catabolism increases, and due to which protein synthesis is reduced. So what happened, we can see the patient become lean when they are in a critical ICU or in a critical illness for a prolonged time. So, due to these conditions, as my glucose is not properly stored in the liver, and glucose can't be used for the longer duration, then it will spare with the protein. So, protein are coming from the muscle, and the muscle breakdown will be there. Then with that, fat breakdown will be there. So these are the condition which occur due to growth hormone increases. Along with that, there will be hyperglycemia, because excessive release of glucose from the liver, and it is due to glucagon, which is more active, proactive, becoming proactive while the insulin is not having the proper activity. Along with that, hyperlipidemia will occur due to more lipolysis fat cells productions. Along with that, hypercatabolic state and muscle wasting we can see here. So this is the condition of the hormonal state. Along with that, we will see some metabolic changes. First, hypermetabolism. Hypermetabolism means more energy production or more energy expenditure in a particular cycle or particular process. So here what happened, tissue repair, fight against infection, these are the condition we can see. Like we have to fight against various types of injuries, various types of surgeries during the ICU ward. So at that time we need more high metabolism to build up my tissues, to build up, cure myself and recover myself from that phase. So for that, these metabolic changes need hypermetabolism. Then we are having protein catabolism. In the protein catabolism, we are having breakdown of the protein cells which are there in our muscles. Okay, so this breakdown is to give glucose to the body, like gluconeogenesis from the non-proteins, non carbohydrate source. We usually get that. So gluconeogenesis was one of the part. Along with that, to build up my immunity, to build up the immune cells, we need that protein for tissue repair, which where protein play a vital role. Then we are having negative nitrogen balance. So in the negative nitrogen balance, protein synthesis is reduced, and due to which muscle mass has been reduced. Insulin resistance, I already discussed that in growth hormones, due to growth hormone excessive, we have to see that there will be insulin resistance. Then increased fat mobilizations means fat cells are break down and move to the body for further use of energy. We need more energy at that time. So there will be rapid wasting of muscle wasting along with organ dysfunction we can see. So from this picture, okay, before going for this picture, we are having this more mm, like detailed one, like in a trauma burn case, which is one of the most critical condition we usually consider, or sepsis means there is infection all over the body. So in these condition we can see neuroendocrine changes. So here catabolic hormones are increases, whereas anabolic hormones are decreases, due to which our muscle, skeletal muscle, whatever muscle is present in our body, there will be proteolysis and production of the means glucose from the muscle, gluconeogenesis. For the repair, we need protein. It will be taken from the muscle. Like that, amino acid synthesis is increases. But what happened? Amino acid synthesis is only occur by the breakdown, not that amino acid will produce protein. Okay, so due to the excessive increase of amino acid, these will go on for the gluconeogenesis, for the glycogenolysis and protein synthesis. But protein synthesis is there for the acute phase, not for the chronic phase. For the chronic critical illness, there will be protein breakdown. Then there are some inflammatory response like cytokine storm. As I told you, cytokine increases in rapidly, due to which growth hormone increases, right? Likewise, sympathetic response like catecholamine. So catecholamines are increases in a larger amount. Along with that, in the liver, we see glycogen stores are decreased, and due to which it produce more glucose in the body because it is needed for our energy. And for the adipose tissues, there will be lipolysis and excessive production of the fatty acid and the glycerol. So due to these fatty acids, it has been seen that the patient is having some cardiac issues due to hyperlipidemia. So these are the conditions we can see when a patient is admitted in a critical care for a longer duration or for acute phase. Let's move on to the goal. So as a nutritionist or a dietitians, we have to first look into the goals. Why, what are first our important aim or objectives to deal with the patient in the ICU ward. So first one is adequate energy and protein. Okay, so why energy and protein? First of all, you need more energy because glucose is not stored in the liver, insulin is not properly working, so we need more energy through the diet so that our body can use that glucose from that food. With that, protein requirement to recover that muscle loss. So definitely protein requirement, we usually in a normal condition we usually take 0.8 gram per kg per day. In that case, it will increase up to 1 to 1.2 gram per kg per day. Then we have to take molecular forms of amino acids to enhance the immune function of our body. Okay. Apart from that, we have to check the gastrointestinal integrity because it has seen that ICU patients mostly can't able to take or chew the food, so we have to give them a molecular one. So with that molecular one, so that they are not having any issues with the GI. Along with that, we have to give them fast recovery, like antibiotics are given from outside, molecular amino acids are giving. So like that, what happened, rapid wound healing and tissue repair we can see there. And apart from these nutrition support, apart from the recovery and the survival, we have to check there should not be any complications and infection. You have heard that some patients having surgery with the bone. Okay, so they do the surgery with the plating and all like that. So due to that metal, there will be infection. So we have to give them enough amount of antibiotics or the antioxidant rich food so that there will be less infections in their body. So these, in this way we will give them nutrition supports to the ICU patients. So now we will discuss which type of nutrition support we usually give to the ICU patients. So first we are having oral nutrition support. So in the oral nutrition support, we are having various types of supplements. Okay. So when a patient is in a ICU clinic, they can drink water, right? So if they are not that much critical, so in those water, we can give a spoon of any type of nutrition supplement, which they can easily digest. So for which patients we usually give them, who have very less appetite, who have difficulty of chewing and swallowing, the patient having increased the nutritional goals or nutritional needs had means energy is increased in their demand, they are recovering from any illness or surgery, and they have to fulfill their dietary requirement. Suppose for a elderly people, we have seen that they have this problem with the chewing, they have this problem with the swallowing. So we usually give them these types of supplements which they can just, it can be powder form or it can be tablet form. So in a powder form, they just stir it into the water and have it. So like that, these types of nutritional supplement or formulated foods we usually give by mouth. So these are oral nutrition support. So what are these? Here you can see Complan shake is there, Ensure is there, then collagen is there. So various types of are there, Fortisip. So various company actually means what we say, they usually build these types of products so that critical care patients can have it. So here basically high protein beverages are there, meal replacement shakes, nutritional powder mixed with milk and water. So fortified foods, what we can see here, like milk fortified with protein powder. Cereals are enriched with vitamin A, vitamin K, D, like that, and also minerals, calcium, selenium, we can give them. Energy dense snacks, we can easily give them. And in therapeutic diet, we are giving them high protein diet for wound healing, special diets for them. Then high calorie diet for underweight patients. Like for a cancer patient, we usually recommend high calorie diet because there will be much more catabolism. So we have to see, uh, we have to check their weight consistently. Then low sodium diet for the hypertension patients. So this nutritional support, this oral nutritional support only giving to the patients who are having problem to have the normal food. It is not for the patients who can't able to, who are not conscious. Okay, it is for the patients who have like feeding problems, who are much better than a patient having a tube feeding. Like that, for them we can give them. But what happened, we can see that these are having limited sources, and along with that they are not adequate like our full diet plan. So we have to check whether after this feeding, um, after longer duration, they can have the normal food or not, because that is the most important way to give them nutrients. Let's move on to the enteral nutrition. This is the second one. Enteral nutrition means tube feeding. Okay. So in enteral nutrition, the patient who can't swallow, who can't chew, who have some surgery in the mouth, in the esophagus, in the GI tract, or who is not totally conscious. Okay, so for them we usually give these things. So there are few surgeries we can see, like nasogastric tube. Their tube feeding and the surgical part is also there. So nasogastric tube means from the nose, and it is going to the gastric, means the stomach. Okay, so for them this nasogastric tube is there, but it is inserted for a shorter duration, not for longer, means 4 to 6 weeks. But for nasojejunal, we usually give it to the jejunum, means if there is operation in the stomach and like that, so we insert it to the jejunum from the nose. So there is high risk for aspiration. There is a chances the patient can't able to take it and vomit it. There is a chance. Then gastrectomy, it is a tube which is inserted through a surgery to the abdomen. Okay, from the stomach to the abdomen. So we usually tell them it is a peg, that is percutaneous endoscopy gastrectomy. So long-term feeding, it has seen that for many years they are actually having this. Then jejunostomy, a tube is going to the jejunum for the feeding, and it is for severe reflux. If there is a patient having a gastric ulcer, so for them we usually give these types of means tube, and for pancreatitis also we give this. So these types of enteral feeding are considered one of the important way, so that the patient can fulfill the demand. And here we usually give the carbohydrate, protein, fat, and along with the vitamin and minerals in the not in the molecular form, but mostly in the semi-solid form. Okay, so here are some modes. There are three modes of this feeding. First one is continuous mode. Means nutrient are delivering continuously using a pump 16 to 24 hours. And what happened here, better tolerance is there, there should not be any gap like that. But in intermediate feeding, what we see that for several days we are giving a feeding at a regular interval, but it should not, it is different from the continuous feeding. Continuous feeding need, it should be given 16 to 24 hours, not like for 2 hours I'm giving the feeding, then after 2 hours I will give the feeding, like that. But for intermediate, we are giving this for several days, but in a regular interval. Like we usually have the meal, we usually have the meal, suppose in the morning I 8 a.m. I am having the meal, then 12 p.m. I am having the meal, like that. Bolus feeding is another type where a large amount of feed over a short time we give through the syringe. Okay, like for tube, we push through the syringe. It is one of the convenient one, but it need a specialist, need an expert to do that. Now we are having some types of formulas for the enteral. like whole proteins are there, fats and carbohydrates are there. We give them usually through the tube feeding. Then elemental are there, semi elemental and disease specific will be there. Okay, you have heard about diabetes plus. Okay, so they are disease specific. So for that, in a enter also there are disease specific formulas. Let's move on to the diagram. So here in the diagram, I am showing you how it is going to enter the tube. Nasogastric means from the nose, it will enter directly to the gastric. Nasoduodenal from the nose to the duodenum, and jejunum from the nose to the jejunum part. But uh, gastrectomy, jejunostomy are actually the surgery. Means with the endoscopic surgery, they usually enter the tube directly to the place. For jejunostomy, they enter to the jejunum. For the gastrectomy, to the stomach. So in this way, they usually do the tube feeding. So here we see few complications like vomiting, nausea. It is very common complications. And what happens sometimes, tubes are having blockage, food are not entering directly. There will be a balance, should be there, electrolyte balance which we are giving them. There is a chance of hyperglycemia. So these are there. But what we say that for in comparison to parenteral feeding, enteral feeding also giving a larger quantity of nutrient, and it also fulfill most of the requirement. But in the parenteral, which we discuss in the next, here we are giving the only the molecular ones. Okay, so here we are giving food directly to the bloodstream. So we can't give the semi-solid or liquid one. We have to give the molecular one. So here we are only giving the carbohydrate in the dextrose form, amino acids in a very, means amino acid form, not the protein ones. Okay, then lipid in a emulsion forms, fatty acids we are giving to them, electrolytes which are in a molecular one we are giving to them through the syringe, and then trace vitamin and minerals. Okay, so here are two processes through which we usually give them. One is peripheral parenteral nutrition, where through the peripheral vein the food is injected, and total parenteral nutrition, which is through the central vein. Okay, so here see the picture for the peripheral vein. We will see that intravenous food is giving. So usually we give this, but when the veins are not that much, like the patient are not in that conscious, that time we go for total parenteral nutrition. Okay, so these are usually given to the patient having a severe surgery, having like going through local anesthesia, means sorry, general anesthesia. They can't take the food properly. So in that case, we usually give through this. It's like saline is giving through this only. Okay. So let's move on to early nutrition support. So now we will discuss about the early and the delayed one. So in the early nutritional support, what we see, if within the surgery or within the critical condition of 24 to 48 hours, we are giving this, and in this way, their immunity will be built up more easily, and the inflammation will reduce more in this case when we are giving them from the early stage, and malnutrition can be prevented. So here, what are the physiological condition? First, it will preserve the gastrointestinal function, like it will reduce the atrophy of the GI tract, and it will also enhance our ability to have the food. Like you have seen, within 24 hours usually some liquid is given to the patient after surgery. So any type of liquid, can be black tea, it can be coconut water, like that some liquid have to be given, glucose water, like that we usually give to the patient. So it will actually restart your GI tract. Okay, and also gives us energy. Then it also prevent bacterial translocation. With this early feeding, it has been seen that our bacteria is present in everywhere, in the mouth, in the GI tract, everywhere there is bacteria, right? So for that, we have to increase the good bacteria and reduce the bad bacteria. For that, we have to uh, maintain the bacterial microbiota and reduce any types of infection and sepsis in the body. We need these types of early feeding. Okay, so gut barrier have to be maintained with that method, and also it will enhance the immunity, and muscle breakdown can be reduced easily with the help of the early introduction of the feeding, and any types of clinical outcome can be reduced. But in a delayed feeding, what we see that after 5 to 7 days, if a patient is have to be given any parental nutrition, it also giving some overfeeding condition, it is giving metabolic stress, and it also cause various types of issues like body is already not responding to various types of nutrients, already lost so much, uh, we can say glycogen, fat is reduced, uh, muscle is reduced, so there is a chance of sarcopenia we can see in these patients of delayed nutrition support. So, what are the risks we see? Excessive muscle wasting, excessive uh, means there is a risk of wound healing, like there is a chance of sepsis, there will be motility risk. So, patient reduce the strength to walk, like this we can see in the delayed nutrition support. So let's see some current guidelines for the nutrition support. First, we will look into ESPN nutrition support care. What they do actually, first they do the screening. Screening process should be done within 24 hours or within 5 hours of the patient. Means what is the condition of the patient. After that, every 1 day there will be screening. Means 48 hours there will be screening, like that every day 72 hours. Then they have to check which route is adequate for them to have the food, so either enteral or parenteral. Okay, basically ESPN will recommend the enteral one. Then they will look into the protein requirement, the energy requirement, and in the protein they usually give 1.3 gram per kg per day for the initial start, and then it will reduce to 1 gram, and it will adjust according to the needs. And for the energy, it will be 20 to 24 kilocalorie per kg per day for the early phase. Then we will manage according to the requirement of the patient. So early feeding, ESPN actually recommend early feeding. It will prevent various types of complications. So I already discussed this. So let's move on to ASPN, that is American Association. So their guidelines. So in ASPN, we are having some guidelines that they also recommend the early feeding one, and with that early feeding, they actually maintain the nutritional intestinal barrier function, reduce the infection or sepsis rate, and improve the clinical outcome. So with that, they actually believe in endogenous energy stores. So they give parenteral nutrition basically, and if it is delayed one, okay. So in this way, they are dealing. So here, what will be the nutritional support for the parental in the early phase? We will check. So first, the energy we will give 25 to 30 kilocalorie per kg per day. Protein will be 1.2 to 2 gram per kg per day, and glycemic load should be maintained. If a patient is having higher glycemic index, sorry, glycemic level, glucose level, that is 140 to 180, then we have to control the glycemic index. Okay, so in this way, we have to give the food according to the need. Now we will look into the nutrition requirement. So here in the acute phase, means from 0 to 2 days, we have to give them 15 kilocalorie and 1 gram per kg per day protein. Okay. Then for late phase, means 2 to 7 days, 15 to 25 kilocalorie per kg, and protein will increase 1.2 to 1.5 gram per kg. After post acute chronic phase, means after any chronic condition, So there will be 7 means after 7 days we will consider 25 to 30 kilocalorie per day per kg, and 1.5 to 2 gram per kg per day. And after the 7 days for the acute recovery, okay, so there will be 25 to 30 plus kilocalories according to the need, and 1.5 to 2 gram per kg protein. So in this way we actually plan the diet of the patient, because protein is very much important. I already discussed that. So here you can see why calories are important. I already discussed the amount, so just look into the requirement. We have to give them enough energy so that they can recover fast. Your body metabolism can be gone through in a smooth way. So for this only we need energy. But if there is overfeeding, it will cause hyperglycemia and respiratory issues. Along with that, for protein also, for preventing muscle wasting, for building up our immune system, to enhance the wound healing, we need that. And for carbohydrate, for the energy source, fat is also for the energy source. And glucose monitoring is very important in the case of patient having 140 to 180 glucose level. Then fluid requirement, it should be 25 to 35 ml per day per kg should be taken. Proper hydration is very important for proper circulation of the nutrients also, and it depend upon the need. Like for a chronic kidney failure patient who is not going through dialysis, we have to control the fluid requirement. It should be controlled according to the output of the patient. If output is 500 ml, you can give them 600 ml of fluid, or if it is output is 1 liter, then we can give them 1 liter to 1.2 liter we can give them. Okay. Then electrolyte, sodium is play a vital role to prevent dehydration and maintain the electrolyte. Along with the potassium also work like that. Calcium helps to more recovery in the bone and the cardiac muscle. And then magnesium helps for the muscle and the nerve functioning. Phosphate actually help in cellular level. So in this way, electrolyte balance is very much important. And with the help of that, we will look into the vitamin part. Vitamin fat soluble vitamins have to be given to support the immune defense and wound healing, along with the muscle functioning. And other water soluble vitamins helps in antioxidant, prevent any types of oxidative stress in our body, and also provide energy. So stress elements are there, like zinc help for tissue repair and immune system. Selenium works as antioxidant to prevent any oxidative stress. Copper also helps in oxygen transport, and iron to maintain the hemoglobin level. It has been seen that patients are dealing with anemia after the ICU. So let's move on to the next part, that is muscle wasting and sarcopenia in critical illness. So in critical ill patient, in throughout this slide I discussed that they are going through muscle breakdown. So as their skeletal muscle is broken down so much, they are dealing with muscle wasting, and severe and prolonged muscle wasting, which is not recovered by the nutrient properly, that will lead to sarcopenia, which is a condition where excessive amount of muscle loss and strength has been seen, so they can't able to do any types of physical activity. So during this condition, hypercatabolic condition, we have to replenish these with the help of the nutrition support. So let's see how muscle atrophy is working. So there's a mechanism. So in muscle atrophy, where the muscle wasting and sarcopenia is already occurred, here more catabolism has been there in the body and anabolism is reduced. Along with that, there is inflammation. Inflammation in the critical condition, sepsis will be there, organ failure will be there, due to which it may occur. Immobilization, as consistently I am sitting or I am sleeping. So you have seen the patients who are bedridden, they are having bed sores. Bed sores are occurred due to excessive amount of protein breakdown in the body, and which can't be used. Then there is malnutrition. Delayed introduction of the nutrition will lead to these types of issues. Hyperglycemia is another condition where mitochondrial functioning has been reduced and the muscle atrophy is increased. Then some medication like we are having catecholamine, we are having aminoglycoside, with that neuromuscular blocking agents. These are various types of steroids we are taking. So these will indirectly cause muscle atrophy. And mechanical ventilation, where the excessive support, prolonged support, and non-spontaneous breathing, PEEP, these types of things occur, due to which diaphragm injury is occurring and it will cause muscle atrophy. So these are the reasons why muscle atrophy usually occur. Now we will look into the muscle fibers, how they are working in this condition. So as mitochondrial activity is reduced due to hyperglycemia, so we have seen that calcium handling is reduced. And with that, there will be fatigue in the patient, and due to which there is issues with the muscle wasting. Then anabolism resistance. So as no amount of synthesis is occurring, due to which it can't replenish it. Then we are having epigenetic alterations. It has been seen that if your genes are very strong along for the muscle building, then there is a less chance you are dealing with muscle atrophy. And if your genes are not working properly, then there is a chances. With that, there is p53 dependent senescence will cause muscle cell wasting and myoblast is occurring. Okay. With that senescence, it has been seen that humans are having various limited amount of this, and therapeutic support is very important over here. With the autophagy, in the autophagy condition, it has been seen that patients having in the ICU dealing with more autophagy, and due to which it has been seen there is blocking the production of the muscle in the body. And there is excessive amount of like the pathway is very lengthy. Okay, when we are dealing with any type of critical patient, they are mostly having issues with building up. Okay, means recovery phase. If recovery phase is having enough amount of protein, energy, vitamin and minerals, fats, then early support is very important. Within 20 to 24 to 48 hours, if they get enough amount of support in a molecular level also, their recovery will be faster. But if it is lengthier than 7 days, then the recovery will be very slow, very slow. So now we will see the sarcopenia risk factors. So if there is sarcopenia, what are the risk factor will be there? There is hormonal dysregulation, inflammation will increase in the body, sepsis will be there, chronic conditions will increase like multi-organ failure we can see. Genes also are one of the factor which will lead to sarcopenia. Old age, definitely. A old patient recovery is much slower than a young patient. Poor diet, as I told you. Physical inactivity, it always said that the patient, after the surgery, after whatever critical surgery, within 7 days they have to walk with the help of assistant. So it will enhance the muscle, and it will reduce the chance of sarcopenia. Abdominal obesity, mitochondrial dysfunction, these are the condition due to which sarcopenia chances increases. What are the clinical consequences we can see usually due to this muscle wasting? Limbs are not working. There will be numbness in the limbs. There will be blockage of the bones, and there will be respiratory muscle weakness. There will be problem with the respirations and difficulty to stand, walk, and do any type of activity. So mobility problem will be there. So what are the assessment after this? We usually after any surgery in a patient in the ICU, we usually do ultrasound, CT scan, bioelectrical impedance analysis, and with that hand grip strength test. So hand grip strength test, you like grip test this like this. Okay, so this assessment we usually do. Now the role of nutrition. First and foremost important is protein. Protein requirement have to be maintained according to the RDA, and in the initial stage, the protein will be increased 1 to 1.2 gram per kg per day. It should be given in a supplement form, molecular form, whatever form you are giving. It is very much important. And with that, overfeeding should be avoided, and energy also should be given along with the protein, because what happen, if there is not enough amount of glucose, your protein will work for the energy source, then the muscle building. Then omega-3 fatty acid to reduce the inflammation which occurring during muscle wasting, and vitamin D to strengthen the bones. So these are the important nutrient. Apart from these, we definitely give them calcium and iron, like these types of uh, other vitamin and minerals we usually give them. But these are the most important nutrition we have to give them. Now, what are the early mobilization in the ICU? So what happened if we are doing early mobilization, the patient in a short term, what we see, there will be muscle mass slowly they are going. See, only taking protein through your diet is not enough. You have to strengthen your muscle. Then only muscle will build up. Otherwise, it will put pressure to the kidney. So it will we have to preserve the muscle mass and strength, increase the delirium, like free days. If you are having, if you are free, you have to work for something. Okay, you have to do hand eye coordination, you have to do some types of activity, so it will help to reduce your Alzheimer's or any types of mental issues. Then also it will reduce any type of pneumonia and ventilator issues. In a long term, what we see, that patient will be fully means fully they are recover from that critical condition to a normal days. Okay, they are easily working, their physical activity is normal, their cognitive health is they are very much productive, and along with that they are dealing a life with a quality life. Okay, so in this way, it is very important for us to do early mobilization, that this will actually build up the muscle and the strength. So, in today's topic, in the day two of this session, we discussed about the nutrition support we usually give to the critical illness patients, and which time is very important and how we are giving them. The modes are very differ according to the patient's requirement. And delayed nutrition care and early nutrition care, you already known that which one is very much important, and if you're delaying it also, you have to give them adequate amount of nutrition. Along with that, we discussed the muscle wasting and sarcopenia, which is one of the most concern for the ICU patients. So for dealing with that patient, it will be very much difficult to give them any type of nutrients which are actually enhance their weight. So timing appropriate nutrition is very important for improving their health, their tissue repair, wound healing, and their whole nutrition status. So that's all for today's class. So if you have any question, you can ask me. Thank you, everyone. Any query? Okay. Thank you everyone for joining the session. Tomorrow you are going to have the day three. Then your 3 days workshop will be completed. Thank you everyone.